Welcome to the Eureka Springs Hospital Commission meeting of May 19th. Can I have a roll call, please?
Sharon Doremus, Commissioner.
Vivian Smith, Commissioner.
David Carlisle, Commissioner.
Kate Dreyer, Secretary.
Brian Lather, Vice Chair.
Sandy Martin, Chair.
Jake Roberts, Chief of Staff.
Misty Denovan, 360-degree medicine.
Lana Mills, Nursing.
Cynthia Asbury, CFO.
Jody Edmondson, Interim CEO.
Thank you, and we have quorum. Also, I will entertain a motion to approve the minutes from the April 21st meeting. They are in your packet behind the agenda.
So moved.
Second.
Thank you. Any opposed? All those in favor signify by saying aye.
Aye.
Thank you. The agenda, I'd like to add two items under old business. That will become number 9, right after the 360 presentation. Number 1 is revisit commission meeting times, and number 2 is a finance workshop with City Council. Do I have a motion to approve as amended?
So moved.
Thank you. Do I have a second?
Second.
Thank you. Any opposed? All those in favor signify by saying aye.
Aye.
Thank you. Public comments. Jim Wallace.
Hi, good afternoon. I'm Jim Wallace. Some of you may know me. Are you able to hear me okay?
Yes.
Okay. I noticed some of you are looking at me kind of. I am your elected constable for this area of Eureka Springs, Holiday Island, in the Lakes area. And I'm not here in an official capacity. I see that more as a public service, as well as my firefighting background, which I've served for over 11 years at Inspiration Point. As a part of the focus of public service, I think it would be useful, looking at the seats behind me being empty, if you will find a better time to meet. This seems to be awkward for the community. I mean, it's working out for you guys, I guess, all right, but I'm not seeing a good turnout here. And although you'll be able to view this maybe later on YouTube recordings, it's not quite the same as when you can have people come up here and provide their public comments. So I appreciate your looking into that, and I understand now it's on your agenda to look into that. Thank you. That's all I got.
Thanks, Jim.
Thank you, Jim. Okay. CEO report.
Okay. Last week, we participated in the state-mandated regional drill. It went well. We did identify some strengths and some weaknesses, so we know what we need to focus on going forward. We've also sent out training courses for all of our staff for FEMA. We are meeting tomorrow with the Rural Health Redesign Center to review our service line assessment, and I believe Kate is going to join us for that. June 9th, I gave you each an attachment, but we are going to provide a community education class on Stop the Bleed. It will be held in the lower level of the hospital at 5 p.m. And last week, Sandy presented our $1,500 scholarship at the awards banquet for the Eureka Springs High School.
And that went to Shiloh Goodman, who was an outstanding star. She won several different scholarships. Ours, I think, was the second largest that she received. She's interested in going into radiology. So that's a good thing. She said she'd come and visit us as well.
Nice.
Thank you.
Question.
Any questions?
What time, Jody? Tomorrow is the meeting with the Rural Health Redesign?
11 a.m.
11, thank you. Is that in the upstairs conference room? Or?
Yes, ma'am.
Okay, thank you.
CFO report?
So the first page cover sheet. Next page is our bank account balances with the ending of April 30th. Can reflect through there. The next page is going to be our revenue by cost center by service state. Our revenue has and is going up from previous months. Overall, I mean, we're still not ideally, the end of April was not ideal where we were still to benchmarks of previous. By the end of the month, we were there. So I would say, I mean, we've seen an increase in CT, outpatient services, and our ER visits from April and even into May. Our current month-to-date billing in May has already met and exceeded actually what we have billed for the whole month of April. So our revenue is definitely up, so, given that we're only 18 days of May, so. On the next page is going to be our income statement for the month of April. We did have a loss at the end of the month. It was about $75,000, better than we would expect. We have, within that loss, we had our Forvis cost report audit expense in there, which was a one-time expense. We had some other invoices for one-time expenses like the tree service, Pinnacle IT services, some of those kind of one-time contract fees in there that would kind of impact it into that. And again, we're continuing to look at ways to cut, any cost-saving measures that we need to do, whether it be within staffing or contracts, supplies, anything like that. We continue to look at ways for that, so.
And we have our budget workshop in June, so we'll go over all of that
Yes.
as well. Cerner was in there, wasn't it? We caught up with them?
Yes. All of our Cerner services is current month to date, yes.
Okay. Do you remember how much that was that we?
Our Cerner contract is about $50,000 a month, so I can give you the exact detail on that one.
Okay. Thank you. Any questions?
The 346 ER, that's 346 ER encounters for that period of time? It's on
On those totals on that page,
it's the revenue by cost center page.
yes, that would be how many encounters contributed into that total there on the chart
Nice.
amount, so.
So the IV therapy, did anybody come in just for some IV therapy that was ordered by outside clinic, or is that just therapy generated
Charges.
through the ER?
Through the ER and
Okay.
sometimes through observation stays, so.
Okay. But we had 70 speech therapy visits. That's nice.
On the speech therapy, yeah, that would have been our billable units on therapy. So each one of those quantities kind of break out and vary by department, whether it's a visit or a unit. But
Yeah.
yes, I mean, no, our numbers are definitely up. And like I said, I mean, I compared them to where we're at May 18th, current month, and we've already had more billable revenue in 18 days than we did in those 30 days. So
And
our
we had-
numbers are, I mean, significantly increasing. We're at or exceeding benchmarks of last year's numbers in May, so.
And 24 observation
Yep.
beds, that's
That's real good.
really nice. Do we, since Jacob's here, do we have a way for outreach for if people were needing some IV therapy post-op, or not post-op, but post-inpatient stay somewhere where they could come into our facility and get some outpatient IV care?
I think that's something that would be pretty easy to accommodate. Obviously, we have 24-hour staff. We have the ability to do IV fluids and IV therapy. What I would say for that would be depending on who is initiating that care. If it's coming from any of the primary care physicians in the community or really any of the advanced practitioner providers, all they'd have to do is just give us a call and say, hey, I would love to send this patient in for such and such. And we absolutely could accommodate that.
So instead
Cool.
of sending them back over to Rogers or somewhere to maybe their primary
Yeah.
care is in Rogers, he actually could order that and let us go ahead and carry on that for him, couldn't we?
Oh, absolutely.
Okay.
And we have provided that service in the past where we
Yeah.
have outpatient orders for
Gotcha.
services
That's
just
great.
like that, yes.
So it's a line item we could add to our marketing handout or whatever we end up, when we're working with our new CEO soon, hopefully. Okay, well, thanks. Appreciate it.
Sandy, excuse me, I have a question. On the lab, so I see 13 visits. Is that low? I mean, 13 billable, is that low
So on
for
some
this
of-
volume?
On lab would have been, there was 13 billable units, so it'd been like 13 different orders of things we build in-house that we could bill for. So, yeah, each one of those line items, like I said, they break out by different, whether they're units or encounters and stuff. So we have performed tests in-house on our point-of-care tests that we were able to bill for, so.
And for this many ER visits, is that low?
I mean, the number, I mean, at the end of April was at where we were historically. The first half of the month was slower for the service line, the first half of April, but not the last half, was kind of at our benchmarks.
Okay. Yeah, I'm still puzzled, but
What are you puzzled about?
that there are only 13 billable lab services, and we had this number of ER visits. And I would have thought lab work was part of the ER visits, or is that included in the ER costs?
Some of them are, it depends on what the test is, depends on whether the charge, and some of them we do send out, so Quest and stuff and things like that, they bill for the service if it's sent to them. Because that's the preferred way, because we are an outpatient bill type, so depending on that makes a difference on patient.
So Vivian, and my understanding, basically what you're asking or we're thinking is, so when someone comes in for treatment, normally there would be some lab work done, correct? Am I understanding correctly there?
I would think that would be
Right?
pretty standard, you're
That's
right.
pretty normal, right? So in the billing side of it, it actually is divided up a little differently than what we're seeing here, correct? Am I thinking right, or am I?
Some of the labs, if they're performed in-house, we can bill for them, and if they are a send-out, then Quest, our third-party lab carrier, bills the patient for those, yes.
So in summary, 346 patients probably accounted for more than 13 lab samples being sent off somewhere.
Yes.
Okay.
So when Quest gets involved, I mean, are we receiving anything from that service at all, or is there because of an agreement with Quest, do we get I don't want to call it a kickback? I don't mean.
No, I
to
mean,
use
a lot of
term.
that is with Quest is because of the payers and CMS in the way with Medicare standards on the cost side of it. Some of the tests
Require it to go through Quest.
with, I mean, the QC and the cost to perform the test in-house, it doesn't make financial. I mean,
Okay.
some of it's along those lines, because we might only do 1 or 2 a month, so it wouldn't, that we send them out to Quest, turnaround time's pretty good on those, so then,
I mean, it's pretty well standard everywhere,
Yes.
right? Am
Yes.
I, okay. It's, we're not a lone wolf in the deal. It happens in every hospital, correct? And that,
Yeah.
that agreed.
Thank you.
Any other questions?
No, I'm okay now.
You good? Okay. All right, CNO report. Lana.
I've attached a packet for you with 2 of my reports. One, you'll find the monthly total up to date for ED visits along with EMS daily visit log from the beginning of May until yesterday. Another one is the monthly date from 2020 until as of this morning on the total patient log on those 2 sheets.
You had 2 busy Saturdays in a row.
Yes.
Mostly out-of-towners, do you think?
Some of those were, yes.
But not,
Visitors that were in town.
yeah, that's what I meant when I said out-of-towners.
Yeah.
Yeah,
Yes, correct.
wow.
This side of the river.
Yeah.
Wow.
So it's not,
Good work.
comparing, it's not so terribly bad going back. Cool. Any questions for Lana? Anything else you have to add?
I do,
No.
of course.
Kate does.
So how's the training for our lab staff going?
We do have a full-time lab tech that is there from Sunday until Wednesdays, that is there 12 hours a day. The other days of the week, she is there 6 hours a day, is that correct? And then on the weekends, we have some PRN people that are working. Otherwise, we have the nurses all trained to do POC, to run POC testing and ISTAT testing, so they are able to do that. Also, let's see, the director is finalizing all of the blood bank so that we can get the blood back in-house. And also, you know that June 4th will be our trauma survey, when the state will be in here to do the trauma survey. So that is when the state will be coming in.
Great. So we're ever closer to for the blood products.
I should have an
Being back-
update email. They were trying to get it, Dr. Stubblefield was trying to get me an updated email before the meeting today, so I'm still working on that updated email, waiting on it.
She's
Thank
been
you.
working intentionally slowly to make sure that everything is buttoned up and all the competencies. And so it's been a little slower than we anticipated, but she's doing all the right things.
But I think we had previously attempted to be at a higher level of care, for lack of a better word, than our rural emergency hospital required. Is that?
That's the emergency versus high capacity.
Yeah, before they were doing like high complexity testing for for the blood bank, and
Right.
we need emergency release basically on the blood bank. So that's what we're working for, is to get emergency release blood.
Yeah, that right. Okay, thank you.
Thank you. Any other questions for Lana? Good work, Lana. Thank you. Okay, our stars.
Hello, everybody. So I'll just reintroduce myself because I know a lot of the people online. I don't know who I am. I'm Jacob Roberts. I'm a board-certified emergency medicine physician. I've been practicing since 2001, and most of that's been in Southwest Missouri and Northwest Arkansas. Just to kind of give you guys an idea. We've been here now almost 4 months, and we've been really working on making this conversion from a critical access hospital to a rural emergency hospital. Essentially, in my mind, this is a standalone emergency department. And as such, that's kind of how we, or myself and my team, are approaching management of the emergency department and putting in our policies and procedures that we need to do that kind of bring Eureka Springs up to the level that it should be with any of the emergency departments in our area. Really, I identified kind of a three-prong approach that, from our standpoint, that we want to address this to try to improve everything. Number one, and I can't stress this enough, is providing accurate and timely and compassionate medical care. The product has to speak for itself. I want any of the staff that work in our hospital to be proud of it and to want their family to come to that hospital for treatment. And if that's not the standard, then we need to fix it so that it is. I want my family to be able to come here and be comfortable with that. So that's my number one thing, and we've been working closely with Lana and administration to fix the things that needed to be fixed, kind of update the things that we need to update, and to kind of bring us online. And I can say that in the 3.5 months that we've been here, the change has been substantial. We've had really good support from the administrative team over there to do the things that we need to do, and it's not the same hospital that it was 3 months ago, and it won't be the same hospital 3 months from now. And a year from now, it'll be something this community will be very proud of. And that kind of leads to the second of my approach, which is improving community relations. Obviously, this transition from a critical access hospital to a rural emergency hospital, it's rough. You know, most of these small communities, the hospital is one of the largest employers in the town. And when that happened, there was a lot of change with the workforce. And I certainly can understand why people are upset with that. And then also, I think that over the years, you know, the quality had maybe fallen off some. So some of that concern for the community was probably justified. The first thing we do to fix that is back to number one, improving medical care. Word of mouth is our best advertiser. If we're providing good care, people are coming into our hospital and they have a good experience, they go home and tell their friends and family, and they know about it. Eureka Springs is a small community. I grew up in a real small community. Everyone knows everyone else, and if they have a good experience, you hear about it, If they have a bad experience, they hear about it. And, my goal is to minimize the bad experiences and maximize the good experiences. And then the last thing that I feel that we need to do is be active partners with the hospital administrative staff to improve the finances. A business has to have customers to keep the doors open, and I feel that this hospital truly does provide a good service to the community, but we have to be financially solvent. And I think, I see no reason why we can't do that. If you look at the historical numbers, I think we can hit those and exceed those pretty quickly, especially with our population that we have. Misty and I just got back from a Innovations and Emergency Department Management course that was held in California last month. And it's kind of interesting seminar conference in that it looks at management of emergency departments all across the country, bases them off of volume, everything from rural community hospitals, rural emergency hospitals, critical access, all the way up to your big tertiary referral centers. And every year they do a lot of benchmark data of what the patient populations look like, the volume, what sicknesses people are having, and everything is pointing to our population that is becoming older and having more chronic illness, more complex illness, and that requires more care, more social services. And I'm certainly feeling that in our environment. And that is something that, those types of services, I think, are better managed in the smaller communities closer to home than they are in the bigger areas that are sent out. And those bigger tertiary referral hospitals are overwhelmed. I think most of you guys have had family members that have tried to go to an emergency department in Springfield or Fayetteville or somewhere like that, and they have prolonged waits. They can't get into the hospital. They can't get primary care. And I feel like we're a linchpin in that. I feel like we can certainly help with that. Obviously, as a rural emergency hospital, we don't do admissions, but we do observation stays. And we can also, as we improve these relations with our community and our local providers, we can hopefully improve our local care. And that's something that I'm looking at doing, as well as reaching out to our local providers and try to build those relationships, just like with the IV care that you were talking about. One other thing as far as improving finances, obviously numbers, patients drive those numbers. And so increasing our volume, I think, is going to be the number one driver of that. But another thing is our physicians are all emergency medicine doctors. That's our number one primary job. It's not to say anything about guys who do some emergency medicine, but the vast majority of our doctors do emergency medicine. And because of that, we know how to chart, what we need to chart. We need to do the things. We're graded on the things we have to do to be able to appropriately bill and also complete our charting on time. And I think that's something that Cynthia could relate to, that our charting is improved over what it was, and it will continue to be good. And that's something that we actively monitor to make sure that we do. The last thing I kind of want to touch on is, like I say, I'm a board-certified emergency medicine physician. I belong to the American College of Emergency Medicine, which is our overriding, college for emergency medicine. Say that 3 times. But anyway, they have an accreditation program that they do that basically lists criteria and rates emergency departments based off of their volume. And so, obviously a rural emergency hospital doesn't have the same resources, nor can be held to the same standards as, say, a tertiary referral level 1 trauma center, but they can kind of benchmark what we should be able to do. And that's kind of the guidelines that I'm using to try and structure our care and kind of bring our hospital up over the next year, kind of to where it should be, to be online with not only every other hospital of our size, but to exceed what those hospitals are providing. And so I'm certainly excited. I think that, like I said at the beginning of the next year, this community will be proud of this hospital. There's a lot that we have to do with community outreach to be able to reach all these criteria, everything from, working with our pre-hospital, with our police, our fire department, our paramedics. But I think those are all challenges that we can work on and make better. You guys have any questions for me at all?
I wanted to ask you about the social services idea. What are we looking there as far as underlying things? I mean, it's something, again, we're going to provide the community. Is that what you're looking at?
Well, so obviously, and this is not a Eureka Springs problem. This is a problem everywhere I work. We have lots of patients that have very limited resources, you know, and we can kind of just go down the line on that. You know, we have a lot of elderly patients that don't have family, don't have good family support. They're sick, they have illnesses that, you know, or they're sick enough that may not necessarily meet a hospital admission, which is a CMS term for billing, you know, they run into. But also there's somebody that's very difficult to send home. You know, they can't take care of themselves well. There's a huge need for social services in all of these communities, and we certainly have that need here. You know, that's a classic example. Another one would be, you know, patients that are homeless, that don't have good resources in that regards, that aren't able to access health care the way they need to. Your emergency departments fill that void, and that is something that I feel that Eureka Springs is very crucial to this community, because many of these patients do not have the ability to travel to even Berryville, you know, and I run into that, let alone Northwest Arkansas. So that is something that is on my list of trying to build and make better as far as what social services we have, and a lot of that is going to have to come with liaison with the community.
Right. It's an outreach program, basically, is what it is.
Yes. Outreach and then follow-up type.
Right.
You know, when we identify these patients in the emergency department, we take care of whatever they need at that particular time. How do we keep them from coming back, you know, on a regular basis because they have no other options?
We also have, and I don't know if you've interfaced with UAMS on our telehealth project, but we have access to their services as well, and they have social services, mental health. Mm-hmm. We've been working, I think they've recommended a couple of options for that, so we probably need to get.
That's something I need to look into more. I've certainly used UAMS as telehealth in other avenues, not so much the social aspect of it, and it's spectacular.
Yeah.
You know, obviously their stroke care, their toxicology, their trauma stuff is all top notch.
Yeah. We'll get you together with them on the next visit and stuff, and because I think there's lots of opportunities there that the two of you will spark that we may have overlooked or not recognized, but we can do that easily. Any questions for Dr. Roberts or Mr.?
Thank you, Doc.
Yeah.
That's great.
Appreciate everything that you're doing. We've been getting great feedback.
Oh, thank you very much. I appreciate that.
And your willingness to tackle the community sentiment, because that is critical, and we need to do it. And I think, you know, instead of coming from us, it's going to mean more coming from you and the physicians and the people that actually touch the patients directly. That's going to be important, and I appreciate it. So we're going to unleash you on the community. So get ready, put your Rotary sticker on or something.
Thank you for
getting
getting
really, really close, like I say.
Thanks for getting the charting nailed down. It's a big deal. Thank you.
Thanks for believing in the hospital.
Yeah.
We sure do, and it makes a difference. And I think, and hopefully you found that the commission and the admin staff were open to suggestions. We want to grow. We know how important it is, and we know we've got a lot of work to do. On the revenue side, I wanted to mention, Jody mentioned the meeting with RHRC tomorrow. They're also going to be identifying potential revenue opportunities and financial and operational things, so that should be a real important meeting. And again, there are consultants with the REH. And Jody, that's going to be recorded, is it not?
I have asked them to record it, yes.
Okay, great. So that'll be available to the rest of the commissioners at some point. Great. Thank you very much.
Yeah.
Anything else? Nothing? Okay. Number 9, old business. We had moved our commission meetings, as you remember, from 6 o'clock to 2 o'clock for dealing with some commissioner conflicts and specifically some daycare issues. City Council has asked if we would revisit moving that back to the evening. So I leave it to the council to discuss whether you want to keep it at 2 o'clock or entertain moving it again.
I think when we had it before, our numbers were no different than they are now as far as attendees. And I feel like it has really helped out with the whole group as far as the hour that we're doing now. So the evening hour, listen to me, I don't feel like there's any more strength to having the evening hour than it was because we had nobody coming.
Yeah.
You know, I mean, I know maybe we do now, but still not in the numbers. So I don't feel like the turnout's going to change whether we do it the evening or whether we do it now. That's my own feeling. After the experience of time I've been around, I've not seen any difference in the turnout other than during the strife time.
Yeah.
You know, it's pretty much been the only time we've had any issue there, but that's my personal opinion.
Are there any other times? I mean, does it have to be 2 or 6?
No,
I
it could be a different time. We just need to make sure that schedule is cleared to be able to use the odd and have it recorded and not conflict, because all the meetings are done down here.
Right.
4 p.m. might be an option for this space.
I think we talked about that once before, Kate, and I don't think 4 p.m. was a really
It
good
wasn't
time either.
available here, I think. There's,
What about upstairs in the?
this is the only
this is the only
place that the recording is all set up officially.
Okay.
I do kind of second what Brian was saying, that as long as I had been on the commission, I mean, when we were having our meetings at 6 p.m., months would go by with no one showing up for public comment. I recall we had one lady show up for a personal something with her own, and that was, you know, she just came once, and that was, it seems like, it was many moons ago, and we did have a flurry of public comment there for a while, but that was an anomaly, really, and so,
And
you know.
yeah, and my own feelings about it is I'd love to have it packed out here with people so they could hear the positives of what's going on at the hospital as well as things they want to address that may be a negative or a positive. We've never had the input from the community coming and sitting in our meetings and telling us, you know, what's going on until the strife hit, you know, and so I feel like I don't think we'd accomplish anything by moving it back to 6 o'clock.
Any other comments before I open my mouth?
I agree.
Yeah, no, I tend to agree as well. And part of the reason as well is so the staff can attend during their work hours too. So,
Yeah, then we have to have them.
Yep.
right. Right.
Another possible compromise, we've got, you know, a budget workshop, we've got some opportunities from 360, we'll have some more opportunities from RQ. We could have periodic community meetings that perhaps can be scheduled in the evening.
Like a quarterly community session, is that, once a quarter we would meet at 6 and let everybody know? If we did it quarterly, then it would be on this, the page that the agenda for us, and we would know that the next meeting would be the 6 p.m. quarterly community.
Yeah,
Is
I'd
that
rather not
what you mean?
nail it to quarterly.
Okay,
Because I think it's important we have a good reason
I see what you're saying.
to
Okay.
meet. I mean, quarterly be great, and hopefully when we get things in place, you know, if we could meet monthly, you know, it would be great. It's a little too much, but we can shoot for quarterly, but not commit to quarterly right now.
Oh, I meant that the community, I thought I understood you to say that every now and then one of our regular meetings would be the community meeting.
Oh, I meant it as a separate meeting.
Oh, I misunderstood. My apologies.
That's all right.
Okay,
Because
gotcha.
again, we need to get schedules cleared and all that stuff. So on top of our regular commission meetings, to hold it, like, you know, example, when we kick off telehealth, when we kick off new budget, for example, to explain that, I think that would be well worth it to have a community meeting.
I see what you mean.
Does that make sense to you as well?
Yes.
Okay. Yep, yep.
But as Sandy said, though, with what we've been doing and with everyone being able to be present, we've accomplished a lot. We've seen the progress a lot as far as what's happened, and it's been nice to have that, and so I think that the way we've been doing this forum has really been good for all of us as far as a commission and group of, staffing to be here and be able to, throw things on the table,
You're right.
so.
Agree.
Okay, great. We'll leave it at commission meetings at 2, and then look at least twice a year community meetings, if not quarterly. That okay for the minutes, Kate? Mm-hmm. Okay. And we can involve you more in that as well. Okay. The other thing was the finance workshop to explain our finances to City Council. Tentatively, we had it set for this Wednesday. We want the Arkansas Hospital Association to come up and be present for this, to give a state of the hospitals, particularly REHs, because God knows we are in a real different type of environment with hospitals, and particularly the REHs. So there's been a conflict on that. So I wanted to talk about early June, on schedules that you might have available for a workshop in early June. Anybody have a preference on a date?
As far as what are they saying as far as the REH? Are they available to send someone up here with the flexibility, or are they locked into a
They have
timeframe?
certain dates that they
Okay.
can make it, but, if we give them a date, the option is if they can't make it personally, maybe we can Zoom them in,
Okay.
if that's possible.
I just feel like that meeting needs to not take place unless they're available in some form. I think we need to have them involved, an outside third party, kind of saying, hey, this is what's going on with the hospitals across the state.
Yeah, I do too.
This budget is all driven on that mindset, is how powerful, how strong are we right now? And REH can answer that question, I believe, and tell us where we stand as far as a hospital. I believe we're standing in pretty good shape in overall, but it'd be nice
Compared
for
to the
REH
others,
to be
yeah.
able to tell us and our community that here's where you are, Eureka, this is where your hospital stands. So I just think REH ought to dictate the date.
Yeah, that's
So you're looking
AHA.
You're looking for REH and the
No,
Arkansas
sorry.
Hospital Association, AHA?
AHA.
Okay,
Sorry
gotcha.
about that.
But that's a good point. We might, RHRQ or C might be good to have too in that meeting.
If they could Zoom in?
Yeah.
Well, maybe we could talk to them about it tomorrow, see what they think.
There you go.
Yeah.
That'd be good.
Do we have the ability to do a Zoom call here in the auditorium? We do, okay, good. I just questioning our sound, man.
Screen back there. So if you'd look at your calendars and look at some June dates.
First week of June's the best for me, but don't schedule it around me. I'll be on the other side of the state for about 3 weeks.
Okay, our budget
June.
workshop is on the 2nd.
Okay, it is.
Yeah, and of course, that's going to be one of many budget workshops. We're not going to get everything concluded then. So anytime in that week, Dave, how's your schedule, and Sharon and Vivian?
I won't be available.
You
won't be available.
You won't be available.
Because of surgery, right?
Vivian?
I'll be able to call.
Ryan?
I'm available.
And what was that date?
Dave?
The whole first week.
Yeah, okay.
How about like the 2nd through the 6th?
The first week of June?
Maybe the 5th?
Dave's giving a thumbs up for the first week of June.
Okay, so sometime during the first week of June. Okay, we have no Sharon and Vivian. You can call in anytime that week. Okay, let me double check with the mayor, get some dates and some times. Tightened up probably either Wednesday or Thursday, maybe.
Okay.
That shoots well. And that's the 4th or the 5th. Okay, all right, great.
May I ask a clarifying question?
Sure.
The first Monday in June is our regularly scheduled workshop, and it was supposed to be on the budget. Is that right?
Correct.
But AHA can't come that day. Is that what I'm understanding you to say?
Don't know.
Oh, we don't know. Thank you.
Don't know.
Okay.
Just know Wednesday's out, but don't know how to reschedule it.
So
Don't know what
if AHA can come some other
our
time
budget workshop?
in that, then we would move our first Monday workshop to accommodate whenever AHA could come.
No, I think,
This is 2 meetings.
yeah.
Okay, thank you.
I think,
I'm just slow.
no, you're not. I think our budget workshop needs to stay in our regular workshop.
Okay.
Because we've got a revisiting to do,
Is
you know?
council coming to that?
No.
No, we're not, okay.
No.
Gotcha. That's all right.
And then the second meeting with AHA is with City Council.
Okay.
And that's discussing just how our financials work.
Thank you.
Not a problem. Ask anything you want.
Our workshop is still on the 2nd.
Okay? Anything else on that?
And that's at 2 o'clock?
Staff?
Okay,
Anything?
so it stays unchanged.
So you can zoom in.
Great.
Which would be better
Much better.
because
No, I think I found a workaround, though. I could watch it on YouTube and then just have my phone there and just,
Yeah.
talk on my phone. I tried that, so.
thank you, Avery. Okay, commissioner comments. Vivian?
Yeah, so I went to a meeting the other day, the Carroll County Hometown Health Coalition, and I gave some information to Lana because it was on mental health, a lot of it, and, the clinical aspect of it. But when I introduced myself, I was telling Dave, it was so cute because I told him I was Vivian Smith, hospital commissioner, and she looked at me and said, "I'm sorry." And I said, "You have no idea what's going on over there." So anyway, the more we could get out and tell them about it, about all the things and about the fantastic clinical staff. I mean, my goodness, I'm blown away. So the more we get out there and the more comments we hear like that, and we could change their perception, hopefully. So I just thought I'd share that.
Thank you. That's great. Dave?
I'm pleased to hear that everything, although it's not immediate and not done yet, is progressing, on a rising tide there. And the words about the medical care is improving, or what the perception that I think people are getting is improving with a look to reaching standards and exceeding them. And that's pleasing. Thank you.
Kate?
I think, Jacob, what you're saying about the first 90 days is very encouraging, and your determination for the next 90 days is also very encouraging. Taking things 90 days at a time, I think, is a great way to approach the turnaround and the improvement. And so thank you for your leadership. Thank you for joining us today. And thank you, the three at the table here. We wouldn't be here if it wasn't for y'all. And I know that in my heart, and I'm just most thankful. So thanks for continuing to come back.
Yeah, I think the commission and the group there at the hospital have started to work together very well. I think overall, again, Kate, my hat's off to you for being involved and helping, with them through that time. But I can't say enough about the positives of what's going on. Appreciate you guys very much.
Ditto from everything that they said. Vivian, thank you for representing us at that meeting.
Yeah.
It's going to be an important community connection as well. I just want to say, because what will be picked up won't be the positive things and the progress, unfortunately. Although I wish it would. Some ears are hearing it. We are getting some positive feedback. What will be picked up will be the $600,000 loss. And I would encourage city council or anybody else that wants to pick on that to listen to our workshop. You can attend the workshop, you can't participate in them, but on our budget, they're all anticipated. Correction. Not all of the expenses were anticipated. We didn't anticipate, but we approved a large amount of money to go to technical. That was critical. And we're finding out every day how critical it was for breaches. The rest of that was anticipated, the Cerner backlog paying it. We still are in good shape. We have the potential of growing revenue. As you said, we can go nowhere else but up. And I think the community is starting to feel confident and feel comfortable with the hospital. And the more we get Dr. Roberts, his staff, Lana, Velvet out in the community, the better off we're going to be, because those are the people that they touch and are important to them that they will learn to trust. So with that, that's my only comment. Our next workshop, like I said, is June 2nd, 2 o'clock here. We're going to begin budget. Regular commission meeting is June 16th, 2 o'clock here. And I appreciate everybody's attendance and intention, and appreciate you coming. Motion to adjourn?
So move.
Second.
All in favor? Good. Everybody wants out. All right.